Thank you so much for taking time out of your day to watch this special COVID-19 and MS Summit. We have a lot of great material for you. With so much good information to share, tonight's summit will run longer than 90 minutes. While there are no scheduled breaks, you can press pause at any time, even during the live stream. We are recording the entire event and it will be archived on our website, mscenter.org. The link will be sent out to everyone who registered, so if you missed something or need to turn it off early, you can catch up on your own time. If you pre-registered, you should have received an email with the timed agenda, which will allow you to tune in for the segments you're most looking forward to. I would like to extend a big thank you to Biogen for supporting this event. This COVID-19 summit is just one of the ways that we have brought MS patients and families critical and time-sensitive information during the pandemic. Please check out the COVID-19 education page on mscenter.org for all of the content we have been producing over the last 5 months. I hope that you will also join us for our usual Fall Education Summit on October 17th. It will be held entirely online, and you can register on our website for updates and the link. Another event that has gone completely online is our annual gala. We are so excited to invite everyone to participate in the gala for the first time from the safety of your own home. Registration and viewing is free and open to all. The team has been hard at work planning some great surprises and speakers for you. You can register to watch for free at mscenter.org/gala. With that, let's get started with an update on what we know about COVID-19 and MS with Dr. Enrique Alvarez.
This is Enrique Alvarez. Thanks again for the invitation. I'm one of the neurologists at the Rocky Mountain MS Center. And I'm just going to be giving an update on COVID numbers, cases, and risk factors associated with it. All right, so thank you very much. We are recording this on August 7th, and all the numbers are pretty much up to date through today. So I bring this up just because the numbers do fluctuate so much, so that you're aware of what day we're starting at. We will look at the numbers of COVID cases as well as discuss a little bit the second wave, and then look at some of the risk factors for some of the worst outcomes, whether that might be MS itself, some of the disease-modifying therapies that we use to treat MS, some of the other comorbidities, and some of the different risk factors. If you don't end up confused by the end of some of that discussion, then you haven't been paying too much attention, because I think the data gets really pretty confusing towards the end, but we'll try to understand where both sides of the argument come in as to what are risk factors, what aren't risk factors for MS, as it's a little bit of a controversy that's discussed much between some of the MS docs throughout the world. So let's look at number of cases. These are number of new cases per day throughout the world. And we can see that the numbers initially were really driven up in the US. Number of cases started a little bit earlier in Europe, but they get buried just because the numbers get so big after that. And then we could see that was a little bit of a stabilization and then a kind of a big increase in number of cases again. And one of the arguments that we were hearing is that this wave was a little bit different from the first wave because the death rate really wasn't going up. And part of the delay in that was probably twofold. Initially, we weren't seeing that much of a lag, but remember in the early days, we had a lot of difficulties with testing. And so a lot of patients weren't necessarily getting diagnosed until much later. So patients a lot of times were dying and then kind of being attributed to dying from COVID. Here we can see that the cases for deaths did start to kind of go up more recently, kind of having that lag of several weeks compared to the new cases. So the superimposed are not on the same scale, please realize that. But they're kind of superimposed so that we could kind of see what the trends are as they relate to each other. By the way, all these numbers are coming in through the New York Times, and you can see the website down here below if anybody's interested in looking at this. We can look at this data many different ways through this site, which is kind of an interesting one to kind of play around with. And it's always kind of interesting to look at the data in different ways. So for example, we can look at this world map and understand the areas that are still considered to be hotspots. areas like Italy. Spain's kind of had a recent resurgence, but really it seems to be in the Western Hemisphere that we're starting to kind of have a lot more issues. Now we're in the original month or two in March, for example, we were concentrating mostly in Southern Europe. We can look at this data as well as a per capita rate. And what this kind of really shows is that the cases of COVID have really affected, the entire world. There's areas that aren't well represented, that the numbers appear to be low. And a lot of this, for example, in Africa, that did surpass 1 million cases today, has to do with just poor testing in most of the country, better testing in South Africa, and that's likely why we're seeing the numbers being as high as they are there. There are some exceptions to this rule. So New Zealand and Australia had really preemptive early strategies to combat COVID. And so they were able to keep their numbers low. Kind of similarly with China and some of these other areas. So, Venezuela, we know we're not going to get reliable numbers and things like that. But throughout most of the other world, the rest of the world where we're getting good data from, you can see that the numbers are fairly equally distributed, with cases maybe being 4 times higher in the US than maybe in Canada or things like that. So you can, again, play with this. When we talk about increases, that's easier to increase if your numbers are low. If your numbers were high, it doesn't take much to start to see the numbers going down, those kinds of things. So some of those trend numbers can be a little bit misleading just depending on where you're at. Another great website to get a sense for where the numbers are to look at that Johns Hopkins website. This is another commonly used website. You can see it was updated this morning on August 7th, the European notation of month, day, and then year. So we can see that currently in the US, we are number 1. We're leading the world in the number of cases. We almost are hitting 20 million cases globally. When we look at deaths, we're almost at 750,000 deaths at this point. And again, US is number 1, and we have 160,000 cases. We can see sort of the trend, kind of some very similar curve to what we saw earlier for the world, matching it pretty well. You can get down to the county level through these sites and kind of clicking through some of these other tabs. So again, you can get a lot of information from these websites. And again, the website is here that you can reference to. Going back to this New York Times page, wanted to show sort of the US numbers. And so again, matched up pretty well with the cases that we saw before, and superimposed on this. Again, sorry, I meant this is for the curve for the world, and then the superimposed curve of the US. And we could see that it's matched up pretty well. And then the US numbers are starting to kind of see maybe a little bit of a decline over the last few days. And that doesn't mean that they can't go up like they did at the end of June. But it does give us a sense of kind of where we're doing, what we've done in the past. Another interesting website to look at is the IHME website. This was a great website for modeling. So it gives you a sense for where the numbers are. This is for number of deaths. Again, kind of the second peak of deaths kind of getting delayed in the US. But what this site has been pretty useful for is to try and present some modeling data for where are we going to go. So as we start to think about the school season or things like this, and you can hear the presentation from Teri Schreiner later, which will include a lot more information on this, you can see that things such as wearing masks seem to have, we can predict that they may decrease the numbers significantly. If you ease some restrictions but don't stay where you're at, you might kind of level off. If we don't do much of anything, no mask or anything else like this, we can see that the numbers are predicted to go up much higher than they would otherwise be if we did implement some of these other strategies. So, in other words, this is predicting that masks have a big effect. And the idea for masks is, although we've always traditionally, and I've shown this meme before in some of my updates, discussing how they really help you from spreading it to other people. The reality is that masks also are protective for the wearer, and there's now starting to be some good data that by you wearing a mask, it reduces your chances of getting COVID. And that the masks, if you do get infected, may help reduce how much of the virus you actually get exposed to. And if you get a little bit of virus versus a lot of virus, that can be very helpful in helping you not develop bad form of disease, but allowing you to kind of work almost like a live vaccine and getting some protection that way before getting really sick. And that's maybe accounting for some of the asymptomatic cases that we're seeing now. The predictive modeling is also helpful because one of the things that we really are nervous about are whether or not we're going to have enough hospital beds or ICU beds. So here is looking at the state of New York, and we can see that the number of patients that were hospitalized in mid-April, for example, for most of the month of April, far exceeded the number of beds that were needed. And we would hear stories about having to kind of expand hospital capacity in malls and other convention centers and things like that to try and make room for these patients. You almost saw that the number of beds needed were over twice of those that were available. And that's hospital beds. When you look at ICU beds, we almost needed about 8,000 plus beds, ICU beds, when there were probably about 1,000 beds being available. And this is kind of when you start to hear about 2 patients needing to be hooked up to the same ventilator and other things like that. So again, as we start to kind of look down line, we might have to kind of start saying, are we getting close to kind of getting to the capacity that we have? This was early in New York, but we can look at Arizona, for example. They started having their peak wave in July, and you can see that the number of hospital beds was sufficient to meet the need that was there. But the number of ICU beds for several weeks there were not enough to cover the need that the patients in Arizona needed or had. And you can kind of see again that according to these predictive models, you can almost kind of see that the number of ICU beds is going to get kind of close to being enough later on. So you can go there and look by every state, but pretty much every country, and kind of get a sense for not just where we've been, but kind of get a sense for where we're going to understand a little bit kind of what we should be doing. So let's pivot a little bit and talk about the risks for MS patients and immunosuppression. Risk factors for bad outcomes with COVID have been identified, so we'll talk about that. But does MS or other disease-modifying therapies used to treat MS affect COVID outcomes? So let's look at this. So this is data from Colorado. You can pull data from pretty much any source you want from the US. You can look at this in many different ways. But just trying to kind of highlight some different sources of data. So this is from the Public Health Department for each state. We'll provide usually this data, and this data then gets reported to the CDC, which is where a lot of the data for like the Johns Hopkins gets put together a little bit more globally. So if you look at this, you can see that the number of cases is way much more common, for example, in people who are 20 to 29. These are people that are working and hanging out a lot more in closer groups and things like this. But it's interesting to kind of see a couple of things. One is the death rate, and the other one is the hospitalization rates. I modified these numbers a little bit to include the death rate and the hospitalization, so that the hospitalization includes sort of everything in blue in these columns, because I think it's a little bit more representative, as most people who died also were hospitalized at one point. But you can see that in the first couple of decades of life, that the death rate is very small. And as you start to kind of get into the 50s, you start to get past about 1%, but then it starts to increase really drastically in the 60s, the 70s, and then particularly into the 80s. And the hospitalization rates maybe start a little bit earlier, but kind of fairly stable again through the 30s, and then gradually increasing until you start getting into the 60s, where then they really start to increase again pretty significantly. So again, age is a big factor when we start to look at bad outcomes with COVID. We can look at, this is not, again, MS data, this is all patients. These are a couple of studies that look at comorbidities within MS patients, and we can see that the underlying comorbidity that is kind of most concerning would be cardiovascular disease. These are looking at patients who died and what risk factors they had. And you can see, again, cardiovascular disease is pretty high, then diabetes, chronic respiratory disease. This is probably less so asthma and more things like COPD. High blood pressure is a big one, cancer, and very few patients have no comorbidities. Another study here shows very similar data. If you don't have any comorbidities, the chances of dying is really low. And as you start to accumulate 1 and 2, and then especially 3 and more, you start to get much higher risks of mortality. The big ones, again, tend to be ischemic heart disease, AFib, so kind of going along with the theme of cardiovascular disease, stroke, blood pressure, and things like this. So it kind of gives us a sense of what we might need to look at in MS patients. So let's start looking at some data for MS patients. This is data, again, as of today from the National, this is North American data from the National MS Society, and in collaboration with the consortiums of MS centers. And we can see that this is kind of a voluntary reporting repository of data. There's been 664 cases reported to date, of which most were MS patients. Sorry, almost 802 cases total, and then 764 were MS, with a few NMO spectrum disorders, kind of early disease in MS and things. We can see that out of 802 cases, that we can see that 49 patients have died, and that comes out to a mortality rate of about 6.1%. When we look at that prior couple slides, just kind of looking at that Johns Hopkins data, you can go back and look at it. There were 160,000 deaths in the U.S., almost 5 million cases. So it brings a mortality rate in the U.S. of 3.3%. You could say that this number is a little bit higher than this, but the reality is that this number is not too far away from this number for a number of reasons. One is there's a little bit of lag in reporting and repository data for patients who are still recovering. If they're dying, you don't need to follow them anymore. Nothing's going to change too much after that. But if they're if they're still recovering, you're not going to report them for a little while because you're waiting to see how things turn out, if they recover, if they do go on to die, things like that. So there's a little bit of lag for the people that are surviving. Those patients that are dead are getting reported a little bit earlier. And in this case, kind of similarly, patients kind of in the opposite end, people are getting reported as soon as they have, as they're identified, as a lot of times these are data from the lab. And then it may take 2 or 3 weeks later before they die. So again, not that different in numbers. So you can almost make the argument that MS patients are, if at any risk of developing bad outcomes, particularly death, that risk is not increased tremendously. And for hospitalizations, it's even closer than this. And MS patients do have a few risk factors, as we will talk about a little bit later, that maybe does account for some of this little bit of an increase. So what are some of those things? or let's look at some of the differences that might account for this. So we can look at a lot of difference. This data hasn't been adjusted for anything, so it's just kind of looking to the column of patients that are deceased versus those that are still alive. And we can see that there's that men don't quite do as well as women. There's less percentage of women in the group that died than those that are alive. That the age of patients that have died is older, so nearly almost 15 years older, 15 and a half years older. That they've had MS for almost 7 years more. And so you start to kind of get a sense that, again, age is a big risk factor even within the MS population. The male trend has actually been something that's been seen in non-MS patients as well. So let's look at a few other things. When we look at the different diseases, we can see that there's a little bit of a difference. NMO spectrum disorder patients have a little bit more of a risk of dying from COVID than the MS counterpart. Very similar numbers there. And that probably has to do a little bit with how disabling NMOSD is. Also probably has to do a little bit with the types of drugs that these patients are on compared to MS patients, because these patients tend to get more immunosuppressive type drugs than MS patients. We can look at the type of MS, and we can see that patients that are progressive compared to those that are not progressive have a much higher risk of dying. And that relapsing patients tend to do much better. You can see that those that are alive have a much higher percent chance than those that are dying. And again, this is probably younger patients versus older patients, more disabled patients, less disabled patients. So let's look at disability, and we can see a huge effect of disability. So only 9% of the patients that are alive couldn't walk and still survive, if you want to think about it that way, versus 60% of patients who died were pretty much wheelchair bound. You can see that even cane or walker was associated with kind of a disproportionate increase of death. But those that could fully walk, very few patients, compared to those that were alive. So again, kind of a big risk factor for that increase in disability. Let's look at a few other things. We can look at treatments. And the thing that jumps out to me is that apparently not being treated with a disease-modifying therapy is a bad thing. So many more patients, almost 65% of patients who died with COVID are off of treatment. And I'm just realizing that this number appears to be a little bit off. I think this percentage is about right. If you do add up all these numbers, that percentage probably adds up. If you look at the CD20 therapies, and these are the ones that have been kind of particularly been a little bit more concerning in the US population, at least as a percentage, again, these are lower than those that are alive. So you can almost kind of make the argument by looking at the data this way that that this suggests that these drugs are protective. Tisabra is another high efficacy therapy that's been sort of described as, potentially at higher risk than things like interferons and Copaxone. And so, when we look at it like this, it suggests that some of these drugs could be protective. When we look at comorbidities within MS patients, we can see that most patients have a comorbidity who have bad outcomes. What are some of those comorbidities? The one that jumps out really is cardiovascular disease, almost a 4.5-fold increase. Other things, hypertension increase at some as well. Anything with chronic appears to be bad, maybe a little bit less on the chronic lung disease, but chronic kidney, chronic liver disease is not good. We can see some increases as well with diabetes. More obesity has been linked, but we're not seeing that to be a big risk factor in MS patients. It appears to be fairly small in some other studies as well. So that's some nice data from the US. I guess I'm going to turn and talk a little bit more about treatments and continuing sort of this theme about B-cell therapies. I sometimes call these CD20 directed therapies. That's what they use to take out the B cells, and concentrate on these two drugs. So we can look at similar data from the Swedish registry, and this is where some of the controversy starts to come up. And we can see that, for example, overall, from Sweden, about a third of all patients are on rituximab, 6.5% are on natalizumab or Tisavri. But as you start to look at patients who are diagnosed with COVID, that as a percentage starts to go up. Those who are hospitalized and in the ICU, kind of the same thing with natalizumab. So it doesn't appear to be something specific to rituximab, but something specific to higher efficacy therapies. Now, one of the themes I'm going to start introducing is that when people start to look at it this way, and there's a few other centers that present very similar data, they tend to concentrate on the bad outcomes for those specifically on disease-modifying therapy. And we just showed that, at least in the US, and we'll see that in most other countries as well, that most of the people with bad outcomes are not on a disease-modifying therapy. So this has really got to be coached and framed within a perspective of, within those that are on disease-modifying therapy, these therapies appear to be a little bit more risky than those who are on other disease-modifying therapies. You can also see that progressive disease kind of goes up, that the age goes up a little bit. Again, these numbers start to get really small. Progressive MS kind of goes up as well. All right. So one important thing about B-cell therapies is that you might make the argument that if you really had no B cells, could that be really bad? And to take a step back away from MS, two patients who had genetic diseases that took out their B cells, that basically never had a chance to develop B cells, were able to survive the disease. So it is possible to survive COVID with absolutely zero B cells whatsoever. Again, these two patients were fairly young, which, we have to look at it in the context of all the comorbidities associated with risks. So I'm going to concentrate on just a few papers. There's a lot of different repositories out there that I think help highlight certain things, or that maybe have more cases than other repositories. So this paper already seems like almost ancient. It came out at the end of June, so a whole month ago, pretty much. And it did a really nice job. This group, this is over 300 cases of COVID from a repository from France. And you can see that depending, again, the number of patients on no treatment was higher than on any other treatment. That death, the really dark blue outcome, was worse on no disease-modifying therapy than on any of the other therapies. You can see kind of split in other ways. If we look at this data to try and start doing something that we will call sort of multivariate analysis, where you start to kind of account for what are the effects of all these different things and what then seems to be driving the risks. The first part for that is to look at each one of these things individually and see what the effect is. So initially, let's look at that. We can look at it by age, and we already saw in the US data that older patients, or people who were dying, were older. And again, you can see that again in the French data, nearly, over 10 and close to 15 years, again, very similar to the US data. If you looked at it by disability, so this is the expanded disability status scale. This is a common research scale, clinical scale, used to look at disability. So 10 is dead, 0 is no symptoms at all. If you're dead, you can't get COVID, so that's why you won't see that. But you can see the number of patients that are on the scale, and you can see that those that are having bad outcomes have much higher levels of disability are nearly a level of 6. That means requiring a cane versus a level of 2, which is some interference in function, but able to do most activities, most daily activities. So disability, age are important. Let's look at the effect of drugs. So this is kind of starting to look at, on a scale, if you're on this side, you're at higher risk. So as you get older, there's a little bit of higher risk. Per 10 years, you see an increased risk that's almost 2.5-fold per year. That's a 25% increase, something like that. You can see being male was a little bit worse as far as the outcome, and nearly doubled your risk. If you had comorbidities and the type of comorbidities and kind of how that affected, again, cardiac was a little bit more of an issue. Diabetes is kind of still a big one. This one crosses the line, so it's not really statistically different. Obesity in this case showed a little bit worse of an outcome. Progressive course, worse disability, kind of increasing the risk. And again, this is a perfect example of disabilities that go hand in hand. So higher levels of disability tend to be much more progressive. And so usually if you account for one, the other one kind of tends to fall out a little bit. But this is kind of an interesting part, and I'm going to highlight this as we look at some of the other repository data. If you look at injectable therapies, they almost seem protective. If you look at CD20s clustered here into this group, you can see that they still seem to be protective, but they're maybe not as protective as the other therapies. So if you look at just these people that are on treatment, it can look like these patients are not going to do as well versus these patients. And that's the highlight that I'll try and emphasize throughout this discussion. When we account for all these things and put them all into the model as opposed to just looking at each one individually, you can see that some of them tend to go a little bit hand in hand. And so, for example, the disability tends to drive out that progressive effect. Being male tends to kind of lose out a little bit because men tend to have more likelihood to develop bad MS. So they tend to be more disabled, be in that progressive group. And so the effect of being male tends to kind of drive down. And that effect of drugs basically washed out. And so if you look at what patients are usually being put on those CD20 therapies, well, that's the only drug approved for progressive disease. So those are the drugs that are likely to be prescribed much more commonly for patients that are much more disabled. They tend to be older because they've had MS longer. That's how they accumulated disability. That's how they became progressive. So if you account for that age, that disability, and those kind of factors, the effective drug really washed out from this group. I'm going to turn to a paper that that's been accepted but hasn't been published yet. So this is a draft. And this is coming from the Italian group. They probably have one of the largest registries that I'm at least familiar with. This includes almost 800 patients. And out of that, 13 deaths. So fairly low numbers. One of the things that's a little bit different as opposed to in the US data set where 77% of cases were confirmed by either PCR or serology. In this Italian group, only about a fourth of the patients were really confirmed. Again, they got hit earlier before testing was widely available, and their system got basically inundated so that testing, they had other priorities besides testing, like taking care of patients. If we look at those 13 deaths, 8 were not on treatment. So again, very similar number to what we see in the US, very similar number to what we saw in France, and 11 of those were in the progressive phase. So a vast majority of patients were in this progressive phase. This paper did not look at disability that I could find. And so I think that's one of the limitations on this paper. So when we look at the effect of drugs, if we just looked at the drug classes, you can see again that the higher efficacy therapies, as we tend to think about them, tended to be a little bit riskier and according to this had a higher risk of bad outcomes, compared to patients on interferons and Copaxone. Again, this is looking at people that were on treatment. They removed all those patients off of treatment. So again, you're looking at basically on that death side of things at 5 patients. They did include hospitalizations to get more numbers, but looking at really low numbers again. And again, removing not being on drug. When they did their multivariate analysis, and again, it's approved, so certain things don't come out very well, such as the periods come out as little boxes and things like that. So this is not easy to look at, but I just want to be able to highlight a few different aspects of the data so that we can see that by the time you look at each one of these events versus looking at many different events, as you put into many models, that in the many models, we can see that age still sticks out, that we can see that sex, that women are protective for progressive versus relapsing, that progressive patients have a nearly 2-fold increase in the risk of having bad outcomes. They did look at disability, so I take that back, and it kind of washed out. But let me concentrate on drugs. And this is one that showed that patients on those B-cell therapies had a nearly 2.5-fold increase in the risk of bad outcomes. Again, I think this is mostly concentrating on patients that were on treatment, even though a category here of no therapy is being looked at. And so a little bit different, but the trend for the different types of drugs, I think, still holds very much in line with other therapies. One of the things I'll highlight is that push to kind of really incorporate disability as we look at infections. So this is not data specifically around COVID. This is just looking at serious adverse events and particularly looking at infections. And this is a paper that we had just recently published or recently accepted. It hasn't come out in publication either, so it's still approved, with Dr. Eric Keister and at NYU, New York University. And again, very similar type of analysis. And what we can kind of show again is that when we look at the odds of developing infections, that being male increases the risk of infection. These are all patients on rituximab, by the way. So looking at the B-cell therapies, being on immunosuppressive therapy increase your risk, time on rituximab increase your risk. But look at these numbers and compare them to disability. Being on a wheelchair really increases the risk of infections. And so knowing where your disability level is can very much affect where this is at, and being able to account for this in these analyses becomes really important. If you're in this group, your risk is very small for developing infections. All right, let me go back to the Italian data because I want to concentrate on something else and concentrate a little bit on some of the conflicting data that happens out there. So if we look at steroids, we talked a little bit about the effect, for example, on CD20s of being nearly 2.5-fold higher. When we look at steroid use, that's a 6-fold increase if you had steroids the month before your symptom onset of COVID. This is interesting because if we look at dexamethasone, which is another type of steroid, dexamethasone is actually being one of the drugs that got touted for being used to treat COVID. And we can see that for most of the participants in the study, if they had dexamethasone, it seemed to decrease mortality a little bit. If you looked at patients who were kind of the worst of the worst that were being intubated, it had a huge effect in decreasing mortality in those patients. So I want to highlight a couple things. One is that, we talk about COVID as one disease, but again, it's probably a couple of different things, and that's important to kind of look at. So we talk about sort of the viral response, the virus infection, and then what leads to a lot of the bad outcomes is superimposed immune response that's exaggerated, that it gets out of control and leads to too much inflammation. And that sometimes some of the therapies that do immunosuppressed have been very helpful in this stage of the disease, but they may predispose to a little bit more of a risk in this sense. Again, the data is a little bit hard to interpret because we can see that there's a little bit of different effects depending on what country you're looking at. The numbers are still very small. I think the conclusion is that if we do see an effect of increased death or bad outcomes, that it's a fairly small increase, and that the effect of being very disabled, of being older, of having congestive heart failure, of having COPD, of having diabetes that's not well controlled, all those things probably are going to have much higher risk than the risk of being on a B-cell-directed therapy. So with that, I just summarized basically this part, but we can see that the COVID number cases are still going strong in many parts of the world. Just the big plug about wearing your masks, social separation was effective at reducing the rates throughout most of the world, and trying to maintain social distancing can be very helpful. With that, though, please try to maintain your wellness, keep exercising, keep eating right, get out of the house safely, try and take care of your mental well-being as well, as I think that this becomes very important. And then we won't have questions, but we'll take questions sort of at the end and answer them in future presentations. And with that, I'd just like to say thank you very much for listening today.
Hi, my name is Elissa Berlinger. I'm a licensed clinical social worker, and I am going to present today on MS, COVID-19, and kind of the continued uncertainty that we are dealing with. A little bit about me, as I just said, I'm a licensed clinical social worker, and I have a very close connection with MS. I was diagnosed a little bit more than 10 years ago, and through that I have the honor and the privilege of teaching MS 101 with Kelsey Lance, and I also provide some therapy and supportive services to individuals and loved ones who've been impacted and touched by MS. I am an adjunct faculty member at Metro State in their social work program. So we're going to kind of look at, kind of continual mental well-being as the pandemic has continued to wear on. We are heading into over 5 months now and almost into 6 months of kind of what this new normal is, and kind of just trying to understand, what we're dealing with, kind of these uncertain times and the unknown. They have continued, but they've shifted a little bit through, as we've become a little bit more oriented and familiar to it, but they still feel very familiar in a lot of ways and still uncertain and unknown. And then we'll kind of look a little bit at what is social connections? How does this tie in? How can we manage being social? I think so much of us have longed for reconnecting in the old ways that we used to connect. And what does that mean? What does that look like? And how does that also tie in with mental well-being as we endure here? And I'll provide some resources to kind of help direct you all as well. So we are continuing to experience various feelings related, to the current state of affairs. A lot of feelings that continue to probably come up, whether we're aware of them or not. A lot of anger, a lot of fear, loneliness, resentment, panic, confusion, fatigue, suspicion of others, suspicion of what we read, suspicion of what we hear. Something that I've been thinking a lot about too, around kind of just because we can doesn't mean that we should. And I think that's part of this confusion as well that we've been experiencing with just kind of the continued uncertain times. We don't know when this is going to end, and it's really become uncomfortable to sit with. We don't want to feel these feelings, and I really think a lot of these feelings are related to a continual grief process that we're in. There's things that I think we've seen in to really try to avoid this. We are seeing, unfortunately, increase people who are relapsing, who maybe struggle with substance use, who struggle with eating disorders, increase in other maybe mental health concerns, depression, anxiety, individuals who maybe experience bipolar disorder or going through some manic episodes as a result of just some of the stress and the grief and the uncertainty that's going on and happening right now. And when I think about grief, it's not only just loss, which I think we've all experienced a great amount of loss, but it's also just change and just not knowing, what's going to shake out from this. How are things going to be? And so we're really all uncomfortable right now. And when we think about it, we want grief to be a linear process. We want to mourn, we want to feel our feelings and then kind of move on and have it be just how it used to be. And unfortunately, it's not a linear process. It's something that can often come in waves. It's a process that, we might kind of think we've gotten through something or we've processed through it or it shouldn't be bothering us now. But then either whether we're aware of it or not, something comes up and we realize, oh, wait, I have to reprocess this again. I have new information. I think oftentimes what I'm seeing right now is as this continues to wear on, we've missed birthdays, anniversaries, graduations, now kind of thinking about back to school, weddings. These are all events that we've either traditionally always had something that we've done or we've been able to look forward to being a particular way, and they're not able to be done how we envisioned or how we expected, or maybe even at all, or they're being prolonged or postponed into the future, and who knows when that will be. And so every time that maybe one of these, call them some anniversaries or things that we've been looking for come up, it can bring up some of these same feelings again of anger, of fear, confusion. Why can't I do this? And so we have to kind of process these feelings over and over and over again. And it can feel exhausting and never ending, especially when we're in it. And that also there's this endurance race that we're kind of all having to face right now. So when we think about, continued some of the difficulties with where we're at, there still is really no timeline on when things are going to return to normal. And, what does normal even mean when this is all over? We don't know. As this is endured, we kind of have a new sense of a new normal. Yet we're really not quite comfortable with what this is kind of showing, what this means. And as the reality of the situation continues, it's incredibly painful and uncomfortable. We continue to kind of feel a loss of control, a loss of our sense of safety. And as things have kind of continued to go on, it's shown up in different ways than maybe it did at the beginning of the pandemic. Now maybe having in additional fatigue that might look different than you felt at the beginning. Increased irritability, wanting to isolate more, maybe a longing, wanting to connect more, wanting to pretend that things are safe and back to normal, and increased kind of mistrust or suspicion. And, people around you, even people who you maybe were close to, but as you've maybe seen how everyone has handled, the situation differently, it's maybe made you question certain relationships or question, how you feel comfortable moving through the world. And so all of those things, all these questionings that have gone on are trying to kind of grapple with this loss of control, this loss of life as it was. As I've been thinking about this, I also feel that these feelings are similar to feelings of, what does it mean to continue to live with MS? So at the beginning of this, I thought, okay, this is similar to how it means, how, kind of the beginning processes, the beginning phases of an MS diagnosis. And as this has kind of continued on, I really feel it's kind of continued to parallel an MS diagnosis or chronic condition, really, continuing to have to sit with just not knowing, not the uncertainty of the future. With MS, continuing to wonder, can I trust my body? Can I trust people around me to kind of be there for me, to support me, to take care of me? It can feel lonely. It can feel that you're missing out because people around you are able to do things that you feel like you maybe can't do or aren't able to do or aren't comfortable doing as well. So I think as this kind of wears on, there's a lot of parallel processes happening between an MS diagnosis, kind of as that continues in the phases of that, coupled with just what we're seeing with the pandemic. I think I always say this too, feelings are feelings. I think they are so important to have, and it doesn't necessarily matter where they originate. They are feelings. We can feel sadness. We can feel anger, whether it's from MS, whether it's from just what's happening. And it's what we do with those feelings that are so important. And we don't want to run away from some of these uncomfortable feelings because they're there to tell us something. We don't always know what it is that they're trying to tell us, but they're important. Evolution hasn't taken us away from depression, from sadness, because those feelings are an important part of the human condition. But there are things, so, trying to kind of continue to focus on what can we control, what can't we control. Oftentimes we think we can control things that we can't, and we don't always realize there are things that we can do to control, to help us feel safe, and really trying to kind of recognize, what is it that we can do. Not going to the worst case possible scenario. It can be definitely difficult and challenging as things have continued to wear on, but really trying to kind of not go to this worst case scenario. Recognizing, as I mentioned earlier, feelings and processes around grief are not always linear. There are going to be ups and downs, and it's part of the longevity of what's happening here. And if you're feeling down, don't beat yourself up for it. When you're in it, you're in it. And it is so much more difficult to recognize sometimes that there will be ups around it too. And it's an endurance race, as I keep saying. And part of that is just to be able to recognize these ups and downs. That's how we cope with what's happening and what's going on, and being able to see that. And I said, this acceptance of, all right, this is just what this is. Doesn't mean that I approve of it, that I'm okay with it, but it's being able to just truly accept the current situation and what it is. And that also allows us to feel a little bit more safer. And when I talk about safety, some of it's physical safety, but it's also our emotional safety, our feelings. How do we feel safe with what we feel? And also in control of what we feel, because our feelings are all over the place. I know myself also, I've had really good days and I've had some really rough weeks, and had some strong feelings of sadness that I don't always know where they've come from, but I think a lot of it's just from just how exhausting I think the current situation is and what's going on. There are some physical things and practical things that we can do. Wash our hands, wear masks when we're out in public, continue to keep social distance, connecting with people, virtually on the phone, especially, it cannot always be the most doable or workable to see people face to face right now, but continuing to make an effort to connect virtually. But also, it's also okay to say no. If it feels like it's too much as well. So that can also be part of this, and feeling control and feeling safe. Staying physically active, moving your body. Those are things that are so important. Movement of the body is one of the most powerful things that we can do. And, it's even as little as maybe if you can just use your arms that day, use your arms. If you can just wiggle your toes, wiggle your toes. It's the intentionality around how we stay active. Also, continue to limit intake of news, social media, things of that nature that can help us continue to be more mindful and present of what's happening and help us feel more in control and safe. So as I mentioned, connecting socially continues to be important. It's important in particular for our mental health. And, when we teach MS 101, we talk about the importance of social connections and what that does for making new connections in the brain. But it helps us be able to try to managing it through this. It helps reduce stress. It helps us not feel so lonely. It improves mental well-being. However, though, it can be really difficult to feel comfortable really trusting others right now, as we maybe witness people around us who we thought would handle the pandemic one way, and they're responding in a different way than we expected. Everyone has different feelings on risks that they're willing to take, and really allowing yourself some space to kind of grieve maybe some sadness of maybe people not being how you expected them to be. It can feel really lonely, and when we do that, but really kind of think about what are the risks that we're willing to take, and how can we effectively communicate this to people around us. It's important to make sure that we continue to kind of endure through some of this. We are not through this yet. And, what are different ways that we can try to connect? So, trying to see people socially distance in terms of walks or in backyards where people are, distant and, apart from each other, but being able to see people to just try to feel some sort of connection. It's okay to set boundaries. And so if you're really not okay, seeing people or you need to see them in a particular way, it's okay to hold those boundaries. It can be really scary. It can feel really uncomfortable, but that's actually another way that you can take care of yourself and in this situation. And there are with that too, some people might not like that and might be uncomfortable with that. And that unfortunately comes on them as well. And we have to sometimes tolerate their feelings around it, but it's okay to hold those boundaries. I really believe it's important to kind of try to focus on this present moment. Things aren't how they were, and we don't know how things are going to be. But it's really important to kind of figure out, here we are right now, and what is it that's going on? And part of that is trying to kind of really tune into what we're feeling at this time, at this moment. And it's going to change. And it's okay to feel happy in these times, and it's okay to feel sad and angry. Your feelings are your feelings. You're entitled to feel them. And name them is so important. And that when we can name them, that actually also helps us feel more empowered. Giving yourself space to feel. So when I say that too, it's, talking to loved ones and trusted people. When we do that, it can make our feelings not feel as big or as scary. And it actually makes them not as uncomfortable. It's a little counterintuitive sometimes because it can get in our heads really scary to talk about what we think, what we're feeling, but actually once we get it out, it can feel actually a lot better. Continue to have compassion for yourself, have compassion for others as we really navigate what's happening and what's going on and so much uncertainty. And, it continues to be an unprecedented time. And so really we have to continue to be creative to get our needs met, take care of ourselves, and take care of others around us as well. So as this continues to go on, I'm going to continue to encourage people to kind of continue to take some time for yourself. Some ideas to kind of think about, with helping to be present. Who am I checking in on or connecting with today? What expectations of normal am I letting go of? And how can I do that today as well? Because what is normal anyways? And we don't know what that's going to be, and just trying to kind of be present with what's happening, I think helps with those expectations. What is important to me at this moment and at this moment in time? Is it to keep some of my physical health so that I can be around more? Is it I need to see someone right now that's more important to me? Really trying to think about what's important to me. What are the risks that I'm willing to take, and what am I willing to expose myself or others to? Also, how am I getting outside? Outside's even just maybe feeling the sun on you through the window, or maybe even just sitting outside, maybe not during the day when it's 96 degrees, but maybe at the evening or earlier in the morning when it's not as hot, and just being able to kind of feel that fresh air. Maybe if you can walk around the block, just really trying to be mindful of being able to get outside. Be mindful of kind of sources of where your information's coming from. I think this is important, really trying to kind of find the science and stick with that and use that as your guide. Lifestyle, I'm going to go back to the Rocky Mountain MS Center has a great resource page. And in particular, there's a lifestyle section of it. And it has videos on additional presentations on mental well-being, the importance of leisure and continued physical activity and movement, mindful eating, things of that nature. So just know that there are a lot of different things that you can go to, places that you can turn to, and with trusted, vetted information as well. But I want to thank you all for your time. I know it's a difficult time right now. We're all still trying to kind of endure and thinking about kind of now summer's kind of winding down, especially with school starting. And it's a tough time. And, but I think there's things that we can do to kind of remember that, there's going to be ups and downs. This is part of the long haul, and kind of help remembering that for yourself, if you're having a good day or a bad day, that it's okay, especially the bad days, I think. It's part of the long haul. It's all part of this process. So thank you all, and I will talk with you soon.
Hello, I'm Dr. Teri Schreiner. I'm a pediatric neurologist at Children's Hospital and the Rocky Mountain MS Center. And today I'd like to talk with you about COVID risk and how it affects children. Here's a brief outline of what we'll talk about. First, our understanding of how the coronavirus affects children has evolved in the time since the pandemic began. We'll talk about what we know now, both as children who can be infected by the virus and also children who can spread the virus. And then we'll talk more specifically about pediatric patients with MS and pediatric children who may be children to adults with MS. We'll talk about how the coronavirus affects the siblings and also family members, as there are implications throughout the family of anyone getting sick with coronavirus. Now, when the pandemic began, we had an understanding that kids probably could get infected, but it was not thought to be very often or very severe. We know that the severity is less than that of adults. We'll talk about that in a minute. But we've also learned that kids can get infected. And a recent statistic just showing 2 weeks in July, the last 2 weeks of July, showed almost 100,000 children across the US testing positive for the coronavirus. And since the pandemic began, we think the number is over 300,000. In reality, it may be even greater, as we suspect that not all kids with symptoms are getting tested. When kids are infected, their course tends to be milder. So this is a graph that I took from the Colorado Department of Public Health and Environment website showing cases in Colorado across the age span since the pandemic began. And we see that on the far left, those kids in the first bar, 0 to 9 years old, they're really proportionately a smaller number there compared to other ages. We see that as the kids age, so children between 10 and 19 years old, the number is greater, almost double the number of kids who have tested positive. And then, of course, 20 and beyond becomes a much more significant jump in terms of number of people infected. Importantly, the kids in the youngest age range were very seldomly hospitalized. This blue line here along the far left bar graph shows that there were really a minority of patients hospitalized, and thankfully no deaths in that group. In this next group, between 10 to 19, there was still a minority of patients who were hospitalized, but unfortunately there were 3 deaths. So this calls to mind that there can still be serious complications of coronavirus, but proportionally, we think there are fewer infections and milder infections in these age ranges. But we've also learned that kids, when infected, have a very high viral load. This means the amount of virus within their nasopharynx, their nose and mouth. This is important because a high viral load means that those children can transmit the virus to others. So I've put up some statistics from a German study that was released recently, showing that among 3,300 positive patients in Germany, 29% of the kindergarten-aged patients had a sufficient amount of viral load to transmit the infection to others. When all children aged 0 to 19 were looked at, the number was slightly higher. This is still lower than the transmission rate of patients older than 20, but still, this is a significant proportion of infected children who are able to shed enough virus to infect other people. So this data was also duplicated in a US study showing that youngest children, less than 5 years, have 10 to 100-fold greater amounts of virus in their upper respiratory tract. So again, really giving us the understanding that children can transmit the disease to others. And unfortunately, the disease is not always mild in children. In April, researchers in England reported a handful of cases with multi-system organ disorder as a result of COVID. What this means is there were kids who had coronavirus infections who then went on to have complications involving their lungs, their heart, their GI tract, their skin, even neurologic complications. Now, this is thankfully rare, but it can occur. And this is a study here done in the US showing that in a 2-month period, there were 186 children who met the diagnostic criteria for multi-inflammatory syndrome. And about half of them required ICU care. So although this is very rare, there are important considerations here as we think about the risk of getting the virus in children. Here is a heat map on the left of the United States showing where these 186 cases were found in the study. And we see that thankfully there were few in Colorado compared to other places. So that was a discussion of children in general with coronavirus. Now let's talk for a moment about children with multiple sclerosis. So this is my specialty, and there are many questions that have come up over in these last couple months on my patients, from my patients, and as I think about what is best for them. One is there an increased risk of contracting the virus by having MS? Is there increased severity of COVID-19 when infected? And does it matter which disease-modifying therapy you're on if you were to get infected with coronavirus? Unfortunately, we don't have a lot of information yet, but what we know is, as far as we know, there's no increased risk of COVID-19 due to having MS by itself. The information about risk and disease-modifying therapy is overall reassuring, and my colleague, Dr. Alvarez, has presented on this, or you will hear more from him shortly about that. But there is a real risk among family members of getting the disease, particularly family members who may have comorbidities of their own, obesity, diabetes, hypertension, lung disease. So while there's a risk to my patients, the pediatric MS patients, a real consideration is also the risk to the family in general and what it might mean to family members if that patient gets sick. The National MS Society has put forward some recommendations to help guide us. And conservatively, they say if there is COVID-19 in your community, consider staying home from school. Think about online courses. Avoid crowds, of course. Avoid people who have sick symptoms. And avoid high-touch public areas like the airport or other public transportation. So what can be done? Well, until we have more information, I would recommend for everyone really to use a mask anytime outside the home. Keep distant from others as much as possible. And then an important thing that may not have occurred to some is that the influenza season is coming. And so we want to do everything we can to protect ourselves, not only from coronavirus, but also from influenza. And so when vaccinations are available, please proceed and get your vaccinations. Now, we are actively trying to get more information to answer the question of what does COVID mean to MS patients, both adult patients and pediatric patients. So there is a consortium called the Network of Pediatric MS Centers, of which our group is part. And we are partnering with the COVIMS registry, which is the COVID-19 Infections in MS database, where providers across the country can enter clinical information about their patients who have MS and have had the coronavirus disease, COVID-19. as providers pool information across the age spectrum, we'll have a better idea of how to answer this, the question specifically for MS patients. What does COVID mean to me? So stay tuned. Now, what do we do about school? This is a very pertinent question on the minds of every parent, probably everywhere. But specific to us, we'll talk about the argument for going back and the argument for staying at home with online schooling. So the arguments, the reasons why going back to school is a good idea. Well, I put foremost education. Some kids just don't learn as well over a Zoom call as they do in a physical classroom with a teacher present. So education, for some, will be okay online. For others, it will really suffer. There are benefits to social interaction across the ages that will be limited if kids are at home doing online school, as will physical activity. There's no gym class. We would be potentially contributing to a more sedentary population by having online school. And then we would miss out on all the other things that schools do for our children. School-based meals, vaccinations, healthcare. There are many clinics in high schools, and the social safety net. We would lose teachers as oftentimes the first people to notice something going on wrong with a child or a family. And an important consideration is also parental productivity in their own job. It's very difficult to be productive at work when you're also responsible for monitoring children at home and ensuring that they are doing their homework. So with our economy struggling as it is, there's an argument that we really need to get kids back in school so that parents can be more productive. But there's a strong argument for staying home also. First of all, as I've mentioned, if there are family members that have a higher risk from COVID-19, it may be worth considering keeping kids home, not only to protect the children from illness, but also to protect the family members from illness. We discussed that there's a rare complication of infection in children called the multi-system inflammatory syndrome. I'd like to avoid that at all possible. And then, of course, preventing the community spread of disease is an important consideration. So again, what can be done? Well, to the extent that kids and teachers go back to school, everyone should be wearing masks as able. This is difficult in the younger populations, but as much as possible, children should be wearing masks, as should everybody in the school. Sanitizing hands. We think the virus is spread most efficiently through the air, but it can be on surfaces. So sanitizing hands and surfaces is an important way to combat it. Social distancing as much as able. And then considering attending school on a reduced schedule and potentially in a cohort so that there is less mingling of kids in school and less time spent physically within the building itself. Now, these are some diagrams that the New York Times had in one of their articles over the weekend, showing us what this might look like for young kids to go back. In the top left, we see a bus stop, two families waiting, separated by 6 feet for the bus to come, putting masks on the children as they get on the bus, having far fewer seats available in the bus, again, trying to prevent the interaction of kids at close range. And then the orderly entry of kids every 6 feet into the school, having their temperature taken at the door before going in. So this is what it would ideally look like. What we've seen so far looks more like this hallway, which is, I would say, significantly different. So for whatever reason, Georgia has been in the news lately. And one of the reasons was because of an overnight camp. 76% of over 300 campers and staff became positive within 1 week of this sleep away camp starting. So that's a pretty high transmission. No masks were worn, and there was limited social distancing. Similarly, in Georgia, a high school had to pull back from resuming classes when 9 students and staff tested positive, again within a week of opening. And this picture that I've shown here is from that article. And yet there was another school in Georgia where 250 children had to be sent home to quarantine after 12 students and staff and 2 staff members got sick within the first week. Now, I'd like to highlight this consideration a little bit more, because there may only be 14 people infected in this last bullet point example, but 250 children were sent home because they came into contact with those 14 people. And that is what the Colorado Department of Public Health recommends. This is taken from their website. It is the protocol for schools to follow if there is just one student with confirmed COVID within a school. So that student, the one infected, has to go home for 10 days, usually about 10 days from symptom onset. But the cohort, anyone that came into contact with that one infected student, also has to go home, and this time for 14 days, because that's a longer period of time to see whether or not that child becomes symptomatic. So if the school is not practicing cohorting and having, more typical circulating between classrooms for different subjects, then potentially an entire school might have to be excused and go back to online schooling while the contact tracing occurs to determine who really is at risk. So the implications of this are really huge. On a very short notice, kids and families may need to accommodate to being at home if they were previously at school. And this could happen, sequentially many times over the course of a school year if the virus continues to circulate. Of course, the kids who are sent home with possible exposure would be recommended to be tested as well. So in summary, kids are susceptible to the coronavirus and are likely to have a milder infection, though that's not a rule. Children carry high viral loads and thus are potential vectors for the virus as well. And this is an important consideration for families, whether or not it is the child who has MS or the adult. And then the decision to go back to school is complex, and really we must consider the health of the entire family as we go forward with this. I'd like to thank you for your attention.
Hello, everyone. Thank you for taking the time to participate in this webinar on COVID-19 history and prospects for vaccine. I'm Tim Vollmer, Medical Director for the Rocky Mountain MS Center and co-director of the Rocky Mountain MS Clinic at the Colorado University Hospital at Anschutz. What we're going to talk about today is a little bit more about the history of the virus, where it came from, what all these terms mean that you're hearing, and then talk specifically about where we're at a worldwide level in developing a vaccine that could hopefully stop this pandemic. Now, I'd like to give you a little bit of background on COVID-19. COVID-19 actually stands for Coronavirus Infectious Disease from 2019. It doesn't actually refer to the virus itself, but rather to the pandemic. Coronaviruses that are causing COVID-19 come from a large group of viruses that infect many species of animals. However, it's thought that the main species that's kept this virus going are bats. And it's thought that they've been co-evolving with bats for up to 50 million years. And so bats act as a reservoir for this virus, with the virus periodically mutating, leaving the bat and moving into some other animal population, which then sometimes transmits the disease to humans. Coronavirus was only first identified as a potential human pathogen in 1963 and have since become known as a common cause of just normal colds. In fact, there are 4 known species that cause typical colds that we tend to get in the fall and winter. However, in 2003, SARS-CoV appeared, and I'm going to go over this in more detail. And since then, there's been 2 more. Fundamental difference is these 3 new coronaviruses that have invaded humans now cause very serious disease. So the first virus I want to talk about is SARS-CoV. So that stands for Severe Acute Respiratory Syndrome associated with coronavirus. It appeared in Asia in about 2003 and spread to several dozen countries. We know of at least 8,000 infections, and it killed 774 people, which is a 9.5% death rate. Now that number is probably a bit high because of mild cases not being counted, since we're not good testing for the virus in those days. But nevertheless, you can see it was a very lethal virus, but it wasn't very infectious. It didn't move to that many people. Then in 2012, MERS COVID came out. And this stands for Middle East Respiratory Syndrome. It has similar symptoms to the SARS-CoV, which is severe respiratory distress, chest pain, shortness of breath, and ultimately cardiac and other problems. It was initially reported in Saudi Arabia and then circulated to 27 countries. Again, infected about 2,500 people with 858 deaths, which would give it a 34% death rate. But again, it's probable that there were many people that had mild disease that were not diagnosed. So these were the first of the really aggressive coronaviruses that have been identified entering humans. And then on December 31st, China announced their first reported series of coronavirus cases. First case was actually around November 15th or 17th, I guess. And this is called COVID-19, which stands for Coronavirus Infectious Disease, appearing in 2019. And it's the newest coronavirus to infect humans. But it's infected over 20 million people since November of last year. And there's been 737,000 deaths worldwide. That gives it a death rate of 5.7%. So the major difference between SARS-CoV-2 and SARS-CoV-1 or MERS-CoV is that these were also very lethal, but they were not very infectious. They didn't move through the population very rapidly. And just to emphasize this, if you look at the number of deaths we currently have from the coronavirus 19 or COVID-19, what you see here is that looking at our major tragedies, starting with December 7th, 1941, which was Pearl Harbor being bombed, we lost 2,400 people. 9/11, when the Twin Towers in New York were brought down, lost 3,000 people. Revolutionary War, about 4,400. The Middle East wars that we've been fighting, we've lost 7,000. H1N1 flu pandemic killed almost 12,500. Korean War, 36,000. Vietnam War, 58,000. 1986 flu pandemic, about 100,000. 1957-58 flu pandemic, 116,000, pointing out that flu can be a very lethal disease as well in certain years. And then World War I, we lost 116. And then the next one there is the coronavirus. So the only events that have happened to the US in terms of major tragedies that have killed more people is World War II, the Civil War, and the 1918-1919 flu pandemic, which killed 675,000. And the worry for us in the healthcare field in the US is that this number of 163,000 represents the number of deaths in the last 8 months. And it'll probably be at least 6 and probably 8 months before we have a vaccine. So current public health policies to try to limit the spread are really key. It's likely that we're going to double this number before we get the disease under control. So let's talk about vaccines and development for coronavirus 19, COVID-19. So this is a picture, a mock-up of what the virus looks like. It's a round ball. It has messenger RNA or mRNA as the genetic material inside, has a number of lipids and small proteins. But the major target are these large red things, which are called spike proteins. And these spike proteins are the way that the virus sticks to a cell wall and then invades the cell, causing infection, then spreads throughout the body and causes the severe acute respiratory syndrome that we see. So from a vaccine standpoint, the focus has been primarily on trying to develop a vaccine that targets the spike protein because they think that's the most specific way to prevent this virus from infecting other cells. There's a little bit of immunology I'd like to just briefly review with you about how a vaccine works. So we have cells that are called macrophages. They're throughout the body. They're like little garbage men. They're running through and cleaning things up. They remove dead cells, they remove debris, but they also identify any foreign substances that are in the body, including pathogens, and they engulf them, break them down into small molecules, and then stick them back out on their surface and let the immune cells, T lymphocytes and B lymphocytes, to see them. And these cells have very specific receptors, like a lock and a key. And if the part of the molecule that they put on the surface fits into the lock of the T cell or the B cell, it activates those cells. And then these two cells actually work together to expand and grow and develop many more copies of themselves. And that includes cells that make antibodies, so B cells, like memory B cells. And they also turn them into plasmablasts, which are just factories that are just cranking out lots and lots of antibody of this new type that we need. And then we also developed another type of immune cell called a killer T cell, or a CD8 T cell. And that cell searches for human cells that are infected but still alive. And then it kills them. And then the macrophage digests them up and again processes them back and presents them back to the immune system. So this is it's a beautiful system, but it is key to our survival, and it is what we're going to activate with any vaccine that comes along for COVID-19. So there's several different categories of vaccines in development, and they work through basically four major ways. However, all of them are designed to produce both a T cell and a B cell response. So the traditional way is to use a whole virus. And what you can do is grow the virus in a laboratory, kill the virus, and then mix it with some chemicals and inject it under the skin or into the muscle. And that's a fairly common approach. Then there's the use of a weakened virus. And the first time this ever happened was when Edward Jenner, back in the 1600s, or 1800s, sorry, began to develop an idea for treating smallpox. Smallpox was rampant in those days. And he had an observation that milkmaids working in the milk barn seemed to have less frequent infections with the smallpox and had less severe disease. And it was hypothesized that there was a virus in the cows that was similar to the smallpox that they were getting infected with that then provided them immunity. That's called cowpox, and it's a known virus. And so actually the first human vaccine was taking cowpox and actually exposing humans to that to try to prevent smallpox. And now we do that with a number of different viruses, such as the older vaccine for shingles, which is Zostavax, which is a live varicella virus, but it's been weakened so that in general it doesn't cause severe disease, but causes enough of an infection that you develop an immune response to it. So weakened viruses or killed viruses are the first group. The second group are where you're using another virus separate from the disease virus to actually carry genes from the disease virus into the patients and infect them. And so this is where scientists molecularly generate a hybrid virus that carries some key genes from COVID-19, in most cases, the spike protein. And these viruses are generally ones that are known to infect humans but don't cause disease, or they're viruses where they've been engineered so they can infect the cell, but the virus itself can't replicate and cause a disease. Those are safer than the ones that can replicate because they can mutate theoretically and potentially cause disease. But this is a common approach, particularly with the COVID-19 pandemic. The third approach is simply to make the genes for the spike protein as either DNA or RNA, and engulfing it in these little lipid sacs called plasmids, and injecting those into the muscle, hoping that they attach to the muscle cells or other cells and get incorporated into the cell. And then that DNA and RNA will become active and will produce the spike protein, which will then be recognized as a foreign substance by the body, and an immune response will be made to it. And there's a number of these that are in trials. And then the last one, and one that's probably the safest and also probably one of the easiest ones to both do and expand to large numbers, are the subunit vaccines. And this is where the laboratory simply clones the genes of interest, in this case, the spike gene, insert it into some other cell type that will grow it. And they simply grow it in a petri dish into large numbers, actually in large vats. So they're just making pure spike protein. And then you mix that with some certain chemicals and inject that into the body. And the reason that that's a very popular way is because it's actually very easy to clone genes from pretty much anything. And it's pretty easy to get the genes to work and make the protein that you're interested in. And then you can grow it into very large numbers very easily. And also because it's not a live substance, it's not a virus, it can't cause a subsequent infection. So those are the four major families of viruses or vaccines. In terms of where they're being developed, you can see on the left over here that live virus represents about 7 or so of the vaccines in development, which right now is about 150. Viral vectors, we're using a virus that doesn't cause disease itself to transport the gene of interest into the patient, is a fairly popular one. There's 25 studies doing that. The nucleic acid, which is DNA or RNA just injected directly, is also fairly popular. And then the protein-based ones, as I mentioned, are the subunit vaccines, and those are the most popular and being developed. And the majority is being developed in North America, but China, Europe, and Australia and Asia are also developing vaccines at a rather remarkable rate, with more than 10 molecules each in development. And this is just a summary of where we're at in a growth way with the different vaccine projects. So in terms of RNA and DNA, so the nucleic acid vaccines, there's about 32 of them in development, and about 5 of them have made it into at least phase 1 clinical trials. Of the non-replicating viruses, the viruses that can't copy themselves, replicate themselves, there are 4 of them in clinical trials, including one that's in a phase 2/3, which means if it succeeds here, it could go into the marketplace very quickly. None of the replicating viral vectors have been introduced into humans because we consider these one of the more dangerous ways of doing vaccines. Inactivated viruses are very common. 3 of those already into phase 1/2 studies, both here and in Europe. The live attenuated virus, again, a more risky type of virus. 3 of them are in development, but none are in clinical trials. But we have 59 of the protein subunit vaccines, 2 of which in trials, but these are being moved very rapidly, and I expect them to probably become the predominant vaccine being studied within the next 6 months. And then there's a mixture of other things that are being tried that are not related to COVID, but other infectious disease I think might provide some immunity. And I'm not going to go through this, but this is a list of all the studies that are currently approved to start. And they're a mixture of different types of vaccine approaches. The 5 of them from China, 3 of them are in the US, 1 in Canada, 1 in the UK, et cetera. So this is rather remarkable in terms of vaccine development. There's usually 2 or 3 or 4 companies trying to develop vaccines. Here we have 150. And that's mainly because of this public and private partnership that's been taking place in countries around the world that has pumped a lot more money into this process and allowed people to take higher risks with early stage development. So far, the most promising vaccines, ones that are farthest ahead, the first one's the Moderna messenger RNA virus. This is an RNA that makes the spike protein that's injected into the muscle, which then gets incorporated into muscle cells, and then they make spike protein and expose it to the human immune system. And they've had already published safety data, and they've demonstrated that in humans they can develop antibody responses and immune cell-based responses. We don't know how long they last, but the safety is pretty good. You do see some fevers, pain at the injection site, but nothing serious at this time. The University of Oxford study, this is another live virus. It's not a disease-causing virus, but it is a virus that can infect humans, where they've now inserted the spike protein gene into it, and that's being used in patients. And so far, the safety profile is good, and it does induce significant immunity. Then the Pfizer-BioNTech molecule is another messenger RNA molecule similar to Moderna. And then the last one, the Casino Biologics, is another genetically engineered virus that has the spike protein added to it. This is an adenovirus, of which there are thousands of them, and they're used for vaccinations for many different things. So this is where we're at in terms of vaccine development. And it is remarkable that given that the first patient was identified November 17, 2019, it was first identified in the United States in February or January possibly of this year, that we now have such a large number of studies, some that are already in the phase 2/3 realm. So it's a remarkable development, but we still have some issues. So there are these phase 1 and phase 2 studies are promising. They have neutralizing antibodies. They built CD8 cells. We do not have long-term safety, and how you define long-term safety depends on the nature of the vaccine you're using. That could be 6 months or it could be 10 years. But the key partnerships that are occurring between the government and the private sector, I think, will dramatically decrease the average time of developing a vaccine, which is 10 years, down to a year, which should be the first time in history that's been done. Larger phase 3 trials studies are being started, and they obviously are the key. We have to have successful phase 3 studies before we can begin moving into the clinic to use these vaccines to prevent disease in the future. Now, I'd like to just finish with a comment about whether patients with multiple sclerosis that are on various immunological therapies can use these viruses. Basically, at this time, for most of the therapies, we believe that you can use the vaccines. The only vaccines that would worry us would be the live attenuated coronavirus vaccine, which means that you're actually getting a live coronavirus injected into you. There are two reasons for that. One is that on drugs like Ocrevus and Gilenya type drugs, is that they can suppress the immune system in such a way that can lead to a more severe infection and potentially death. And the other reason has to do with that they cause those vaccines tend to cause more symptoms and more fever as a result of the infection. In multiple sclerosis patients, that can dramatically increase their MS symptoms, sometimes to a critical stage where we have to admit them to the hospital. But those types of viruses are the ones that are farthest behind right now. So I don't think those are going to complicate the use of vaccines by MS patients. And I expect the subunit vaccines, which are the most promising in my view, would be perfect for MS patients. The only other comment I can make about that is that some of the drugs that we use, which includes, again, Gilenya type drugs, Ocrevus like drugs, some of the chemotherapies, will reduce the effectiveness of the vaccine a bit. So it doesn't prevent it, but it may not be quite as effective as it would be if you were not on those therapies. Nevertheless, if it's a subunit or other safe vaccine, we would urge you to proceed with getting the vaccine as soon as you can. So with that, I'd like to thank you all for taking the time to participate in this webinar. And certainly if you have questions, you can submit them to the Rocky Mountain MS Center and we will try to answer them for you. Thank you very much.
There are so many ways to get active while still staying safe. Being outdoors gives you a mental boost as well as physical benefits. This segment will show you just a few of the ways that Rocky Mountain MS Center staff, patients, and clients of KDUP are keeping active during this time. Being in Colorado, we're lucky to have the mountains basically in our backyard. Hiking can be an awesome activity right now. Just remember when you go, look for trails that are lightly trafficked, go during off-peak times if you can, bring your mask, and if you pack it in, pack it out.
Remember when you go hiking to bring a face mask with you so that when you pass hikers on the trail, you can step off the trail with your mask. Happy hiking!
You don't have to get out to the mountains to get in some exercise. You can get out in your own neighborhood. Since I've started working from home, I've made it a point to get up every few hours and walk around my block. If it's a hot day, I'll bring a cooling towel soaked in cold water. Many areas and parks have accessible sidewalks for folks in wheelchairs and walkers.
My name is Jan, and I love to come outside. I'd rather be outside than inside the house. When the days are really nice, I like to come out and do my morning exercises. But any chance I possibly can get, I spend outside. As long as I'm in the shade, I do okay when it's warm out. But even when it's chilly, cold, snowy, I just come outside. It's just really good for you to get vitamin D, and it's just good.
If you plan on hiking or walking outside for an extended period of time, it's recommended that you pack at least half a liter of water per hour that you're going to be exercising. If it's going to be a strenuous hike, or if it's going to be especially hot outside, you should definitely consider taking about a liter for each hour that you're hiking. A half a liter is about 17 ounces. Also, don't forget, if you have furry friends, to bring water along for them too.
When I go for a walk, I like to go in the early mornings because it's cooler and I find that I don't get as tired as fast. And when I'm on my walk, if I know I'm going to be at the neighborhood park where there will be people around and I'm not sure I'll be able to keep my distance, I always make sure to keep my mask in my pocket so I have it handy. So I'm about to take a walk through the park and I'm just going to pop on my mask and I'm ready to go.
You don't even have to leave the house to get in some physical activity. Have you tried a seated workout yet? Check out the Rocky Mountain MS Center's COVID-19 education page for a seated workout from Michelle Harrison that'll get your blood pumping. Stephanie's been taking her class for a few months now.
During these times of COVID, I've been able to stay active through the online exercise class. This class has benefited me in many ways, not only getting physical exercise, but also making body-mind connection and increasing positive energy, connecting with a very supportive group of people has been a big part of my wellness plan during this time of isolation. Very grateful for the experience. Having to have something that is scheduled and create some sort of normalcy in a time of unknown for many people, which is what people with MS experience on top of COVID, has been also really beneficial to have a calendar and a group of people to meet regularly and someone to guide us through that.
Cross and out, cross and out. Weights or no weights, if you get tired of the weights, put them down. If the weight of your hand is enough, if you need to help one hand, we're going to go to one side and the other, right?
Hello, everyone. Get out there, get moving, and stay safe.
Thank you for joining us today, and thank you again to Biogen for their support of this program. We at the Rocky Mountain MS Center hope that you are staying well during this time. If you have questions about COVID-19 and MS, you can email them to education@mscenter.org to be included in a future webinar update. Please make sure that you are on our email list to get notifications about our education programming. Take care.